Okay, then, so we've already done the extraoral examination, and now it's time to do the intraoral examination. The extraoral examination terminates basically at the level of the lips. You've checked out the skin and the neck, the head, the facial structures, fascial spaces externally, and the lip border and all that stuff. And now you're ready to take a look inside the mouth.
All right.
So let's do that.
All right, so let's take a question which I think is pretty clear and obvious is what do you look for when you're doing an intraoral examination? I mean, what kinds of things are you focused on?
Just like the extraoral examination, I like to take a systematic approach to look at the intraoral examination, which is the opposite of, going straight to the tooth, which I suspect is the problem, based on the X-ray that the patient has posted, behind their head by my assistant.
Right.
So I would like to do it systematically by first taking a look at all the soft tissues, then proceed to do a little bit of a quick occlusal examination, and then finally the dentoalveolar examination, which is kind of the meat of the matter, where we're going to spend most of the time in. Okay. But a quick look at the soft tissue examination, taking a look at the mucosa, making sure that everything is in good shape, there are no growths, any ulcerations, or any significant changes in color is important. Of course, as a part, legally speaking, we're all supposed to do an oral cancer examination as well during any endodontic examination. So taking a look at the tongue, pulling the tongue out with a gauze and looking at the lateral border of the tongue, the lateral sides, as well as the dorsum, as well as the floor of the mouth is significant to note any potential changes, any kind of leukoplakia, any ulceration, anything like that. We should make a note of that. And make a note in the patient's chart that an oral cancer examination was performed. It's very important. Taking a look at the throat is obviously a common sense thing. Look at the pharynx area, make sure there is no sign of a pharyngitis, any kind of a problem that could trigger us to think that something might be related to a systemic condition as opposed to a local one. And again, looking at the minor salivary glands, look at the ducts of your salivary glands, see if there is enough proper flow of the saliva is important too. Sometimes patients may, have a blockage of the salivary gland, have pain, exactly, and that could get misdiagnosed. Then we look at the occlusion. And occlusion clearly is something that everyone here at the Spear Education is probably well trained on. It's a significant and important part of the diagnostic process when it comes to restorative work, but it's also related to endodontic work because occlusal interferences can cause pulpitis and periapical inflammation. Now, it's sterile. It's not it doesn't cause irreversible pulpitis on its own. Continued trauma on its own cannot, if it's low grade and it doesn't really sever the neurovascular bundle that comes inside into the tooth, as long as it doesn't do that, it just creates mild inflammation in the patient, but it's enough for the patient to have pain and discomfort. Mm-hmm. So it's important to do a thorough bilateral examination of the occlusion to make sure the patient's mouth is balanced and they're not having interferences that could make a tooth especially sore, because occlusal trauma can very easily mimic odontogenic pain and pulpal pain. So it's important to know that, and you can only do that by checking internally the occlusal status of the teeth. Also, some myofascial dysfunction, for example, a tender lateral pterygoid, could be a source of severe pain to a patient, that is complaining of constant pain. And that is usually a myofascial trigger point associated with it. And if oftentimes you just simply palpate the lateral pterygoid muscle intraorally, you will be able to get a response from the patient in terms of the soreness. So the same way you do the extraoral examination with checking out the masseter muscle, checking out this extent, finding out if your patient is a bruxer, for example, is an important information because it, again, not only fine-tunes you in making a diagnosis so that you could look for cracks and things like that, but also let you inform the patient about the prognosis of the case. Because anything you do on a patient who's a severe bruxer is going to have a lower success rate. Right? Mm-hmm. It's kind of like diabetes. You basically have, if you have uncontrolled diabetes, you have to reduce the number of, your real age is different than your chronological age. So the same thing with bruxers. Unfortunately, their dentition, it doesn't have a real age. It's something beyond the real age is not their chronological age on their dentition. So that's another important thing. But the dentoalveolar exam is basically what you try to hone into, and that's where you spend most of your time doing your diagnostic process. And that starts by doing your alveolar bone examination, your periodontal examination, and then last but not least, you start doing your tooth examination, which will revolve around taking a look at the crown, the pulp, and the apex of the tooth. And so let's take a look at the dentoalveolar examination and how it deals with the bone periodontium and the teeth. So we start by the alveolar bone examination. The alveolar bone examination, Dennis, is basically palpating the bone, making sure the mucosa is dry. It's not filled with saliva, so you're taking a look at the whole mucosa that's covering the bone, whether it's the maxillary alveolar process or the mandibular alveolar process and the body of the mandible. Make sure it's dry, because that's the time where you're going to be taking a look visually to try to see if there are any sinus tracts, any signs of swelling, and you want to palpate that area as well to make sure there are no growths, any exostosis, any softer hard tissue swelling associated with that area. And you're basically checking for a sinus tract. And if you see a sinus tract, you obviously have to trace it immediately.
Right. And keeping in mind that when you do, it's not uncommon to find them quite some distance from the offending tooth. So.
That's a great point. So that you don't, that's why your diagnosis and visualization has to be systematic, because you're trying to look at the whole jaw, because I have seen sinus tracts that have basically been two teeth, distal or mesial, to the site of the infection. So that's an important and significant thing. So the next step would be the periodontal examination, which everybody here is obviously aware of as well. You do your general periodontal examination. Having a full mouth x-ray is really helpful in those situations. But as endodontists, we don't have the luxury of dealing with that. So we have to limit our periodontal examination for an endodontic case that's been referred to us to the area of the problem, basically. Right. And one of the things that I want to really bring up that I actually didn't kind of bring up during the pulp physiology portion is that what's significant about pain and the innervation and the dermatomes in the maxilla and the mandible is that pain will pretty much all the time, the pain will not cross the midline. Mm-hmm. You can have referral patterns along the same side of the body in the head and neck, so that you can have pain that's going to the mandible, to the maxilla, to the side of the head, to the back of the head, but it's always along the same sagittal line. So if you're having pain on the right side, it could be the right mandible, the right maxilla, or the side of the face, but it's always on the right side. Pain does not cross the midline. Yeah. And it's an important thing to ask the patient that, because if the patient is describing a pain that is crossing the midline, then you might be thinking about bilateral pain that might be associated with TMJ or TMD again, and that may not be related to a focal infection such as odontogenic pain. So that's an important thing to realize too. But going back to the periodontal examination, we know that there is a big relationship between endo and perio, and that endodontic disease can cause periodontal disease when you have drainage of an abscess. So periodontal disease in that situation isn't the classic periodontal disease that is caused by an external source, but that's an endoperio lesion where endo is causing the perio. Mm-hmm. And vice versa, if you have periodontal disease that is very advanced, oftentimes manipulation and scaling and root planing of a tooth could cause devitalization as well. So it's important to kind of recognize that and check this periodontal status of the tooth. Also, probing around the tooth is important. Specific patterns of probing are important to keep in mind, because when you have the type of probing in which you have 3, and then suddenly a 7 or something, a narrow, deep probing is oftentimes associated with a crack or a fracture of the root or a split root, although it could sometimes be associated with a draining sinus tract. So we're going to talk about a sulcular sinus tract. We're going to talk about how to decipher the two and some of the other tests that come handy when that's all the information you have. The other thing about periodontal examination is to check for mobility and rule out potential for occlusal trauma. So those are really important things that we need to do for the periodontal examination.
Well, Ali, in terms of the root fracture that you spoke about, one of the things that needs to be clear is the general periodontal condition has to be kept in mind in terms of focusing on the specific.
Yeah.
And the reason why I'm saying that is obviously if you're in a mouth that has multiple areas of periodontal concern and you have a deep probing, even though it might be a singular deep probing, if you have 5 areas in the mouth that also have deep probings, it makes you less suspicious of a fracture.
Yeah.
It's this healthy mouth, generally healthy mouth, that all of a sudden you get that deep probing, that boring.
You're absolutely right. That's why, taking a look at not just one area, but looking everywhere is very helpful. Having a full mouth examination and having access to the full mouth radiographs is very helpful in that sense. Localized, narrow pockets are oftentimes associated with cracks or fractures. But then again, it could also be because of, remember, a sulcular sinus tract could cause that too. Sometimes I've seen cases where there's a furcal problem that's associated with a furcal canal, where an endodontic disease is causing a loss of the total furcation, where by all periodontal standards, that tooth cannot be saved. But when you do the root canal, you realize that the furcation refills completely because that patient doesn't have the basis for periodontal disease. That furcation bone was lost only because of the original cause of endodontic disease, and once the source has been eliminated, the furcation can regenerate. So keep these information all in mind because they're all very important.
So the aim of the periodontal examination as it relates to both the pulpal and the periapical diagnosis is to hone in most specifically on the problem that the patient is actually presenting.
Yeah.
I mean, kind of localizing your focus and getting a sense of what the patient's.
Yeah. Our goal in the pulpal and the periapical examination basically is, first of all, do a series of subjective tests to determine the condition or the status of the pulp and the periapical area. So that's really our goal of what we're doing, is we're just doing a bunch of objective or subjective tests to find out.
Could you just take a moment and distinguish between subjective and objective tests? Because it's, different people have different sense of that.
Of course.
So would you just talk
Well,
about
basically, subjective tests are personal experiences by the patient that they're conveying to us and communicating to us. Okay. Objective experiences are those that we can see for ourselves. So when I put a cold on a tooth and the patient says, I have pain, that's a subjective experience.
Okay.
But when I see swelling, that's an objective experience because it doesn't require the patient to tell me anything or have any kind of feedback from the patient. So it's very important. The more objective the tests, the more clear they are.
So things that I visualize in terms of the subjective, objective, things that I can see with my own eyes, those are the things that we're going to put under objective, and they are things like a sinus tract, a broken tooth, anything related to swelling and so forth. And anything that I am getting from the patient.
Yes, any feedback you get from the patient.
Any feedback from the patient, we're going to continue to call that subjective.
Yeah, that is basically the essence of it. And that's important to know that because we're relying on the patient to be kind of accurate in giving us the right response. It kind of reminds me, just not too long ago, a few days ago, I had a patient who was referred for an examination evaluation. The tooth clearly seemed to have a apical area, and it had every sign that it should be necrotic. But when I was doing the pulp testing, when I was putting the cold on the tooth, the patient was basically giving me a positive response, which didn't make any sense in the big picture of the tooth. So what I did is I did a little trick. I took a Q-tip with no ice on it, and I put it on the tooth, and lo and behold, the hand goes up. I realized it's not a very reliable test on this particular patient, whether the cause was trying to avoid a root canal, or I hadn't communicated properly to her what I was looking for. Maybe she was just the sensation of me pushing was what she was conveying back. Either way, it's important to kind of realize that. I'm glad.
Not mine.
I'm not glad.
But from the perspective of all this testing you're mentioning, it doesn't seem logical that you can test every tooth in the mouth.
No, obviously not. Clearly, yeah, you're basically, especially with your some of the tests that we're going to go into, which is your pulp vitality test and so on. If you try to test every tooth in the mouth, you're going to have a patient that's going to be your, is not going to like you. You're going to be your enemy right away.
Spend the day with you.
Absolutely. So you don't have enough time to do all of those tests.
So where do you start? Do you start on the
side? So here's the key. The thing is we were mentioning is that pain doesn't cross the midline. So you basically try to look, depends on the patient interview portion of the steps. If the patient is fairly sure that the pain is localized to the lower jaw and it's on the right side, then you would test primarily that side. Until you don't get enough information, then you move on to the maxilla on the right side as well. So your job is to stay on the same side, primarily on your testing, and then as you don't have enough information, add sides to it. But it's also important to realize that for every time you're doing your testing on the one side, you're also using 1 or 2 teeth from the other side as control, because that's a significant thing.
Yeah,
so you're not
really
testing
important.
every tooth in the mouth, but you are testing the primary site of pain, and you should try to do as many teeth as you can on that side, and especially on that
percussion. Just as an example,
Yeah.
okay, if systematically you're to the point of and we'll go, how we get there is in just a moment, but if we are going to start to percuss teeth as part of our diagnostic process, you clearly don't go to what you think is the offending tooth and just
bang on it right away.
You got to.
It's the fastest way to make an enemy.
Exactly. So
That's right.
Talk to us about that. Where do you start? You start on the opposite side, the upper quadrant versus the lower quadrant. I know what I do, but I want to hear what do you do.
Yeah, absolutely. I mean, that kind of brings us to the next step, which is doing the tests that are required to do our pulpal and apical diagnosis. And that's the tests that we use to do those with your palpation, percussion, and the vitality test. These are ultimately the tests that we apply to the tooth in order to find out the condition of the pulp and the apex. And let's just kind of go through this systematically.
So we'll do palpation first.
Let's do palpation first.
Okay, and then we'll do percussion.
So on the palpation gives us information only about the periapical area.
Okay.
So what we're going to do with the palpation is basically run our finger gently along the side of the apical area of the tooth. And the information that what we're looking for is first a tactile sensation of what's going on. Once again, also examination to make sure we haven't missed any sinus tracts. And if we have, maybe see if we can express anything out of it, if there is any discharge from the sinus tract. Also, at that point of the palpation is actually when I start to use my finger to press on the teeth on that side. And what that does is it gives me, it's not a valid way of testing for percussion, but what it does is it lets me have a sense of how much pain is this patient in, so that I don't go in there and start percussing with the back of my mirror on a tooth that is so exquisitely sensitive to my touch even. So it just gives me a little sense of what to expect, and therefore I'm able to adjust my percussion test later on based on what I'm getting from that palpation test.
Okay, so this is really the first sense that you have of how much pressure you will use.
Yes.
And if a patient is already giving you a sense that, whoa, this is pretty sensitive on this side, you're going to, although you will start on the other side, you're going to be using less.
Absolutely. I mean, just because at that point I know that my percussion is not, I'm not trying to elicit the most pain out of the patient. I'm just trying to see if I can get a positive or a negative response that would tell me the condition of the periapex.
I've had so many patients come into my office over time and say, the dentist killed me.
Yeah.
He banged right on my tooth that I told him was
the cardinal mistake.
It's the cardinal mistake.
Yes.
And from that point on, I'm working, trying to reconvince that patient that they should continue to go to that dentist.
Yeah.
Okay? And we can talk all at that whole issue of having a patient lose confidence in you.
Yeah.
But your perception of this palpation starting to give you a sense of how hard you're going to do your percussion test, I think is really important.
Yeah, I think that is really the art of the practice. You can get your diagnostic tests many different ways.
Right.
I guess the art is to do it in such way,
to the patient
exactly, that considers the patient's feelings and their right to not experience any discomfort. Granted, some of the tests are going to be a little uncomfortable, and I tell the patients at a time, I wish there was ways that we could do these without putting coal on your tooth. But the goal of diagnosis, as I mentioned, is the duplication of the chief complaint, and the chief complaint is some discomfort. That's just a part of it. I think part of that management part really has to do with communication, and it's very important to tell the patient what they're going to have to expect, and then to be able to then deliver, to deliver just that and not more. You don't want to go in there and, as you said, start banging on the teeth. That is really a poor bedside manner, and it should not be practiced in that way in any way possible.
So, refocusing again and kind of getting back to percussion, what does a percussion test in and of itself tell you? Does it tell you the status of the pulp?
No, it doesn't.
Oh.
It doesn't tell you anything about the status of the pulp because, as we talked about in the little diagram, the pulp biology portion of the course, during a percussion, your tooth and the root is acting as an extension of the back of your mirror. When you're percussing on the tooth, you're actually percussing. It's your tooth that is percussing on the abscess or the inflammation source. So So your mirror is the extension of your finger, and your tooth is the extension of your mirror. So ultimately, it's about pushing. So you could think that the percussion test is almost a palpation test directly into the bone, and that's what it really is all about. Is that you're trying to see what's going on at the periapical area. And that's really the difference between the percussion test that is done by gently percussing on the tooth and try to do that. I usually, as I mentioned, I always try to do that on the contralateral side first. I tell the patient, explain to the patient that this is normal because oftentimes they don't know that. If you just start to bang on teeth, then some people just, it's sensitive to them to bang on any tooth. Mm-hmm. So you have to set a normal level from which you can drive the abnormal. So let's say somebody comes in with a complaint of the lower right molar. I will go ahead and do a little light percussion on a couple of teeth on the lower left, and then I start, and I do that systematically, start from the back and go forward, or from the forward, go back. It doesn't make a difference as long as it's the same way.
Do you say to the patient, I'm going to test the opposite side first just to give you a sense of what normal is?
Yes. Anything you tell the patient no in advance is going to be helpful to that patient because, the same way patients come in with a certain understanding that they're having pain and they want us to understand it, we come from a certain understanding of what is the tests are and what do they mean, but the patient doesn't know that. Right? So you can't make that assumption. And the more you explain to the patient, the better the patient's going to be prepared to give you not only more accurate results, but also to be less surprised and less uncomfortable with the kind of care that you provide to them. So the difference between percussion and the bite test, Dennis, is that the percussion, as I said, is just an extension of your mirror in the periapical area. But the bite test can actually give you information about the pulp as well. Mm. And the reason for that is that the bite test is a function of pressure on the tooth that translates down to the apex. So you do get information about the periapical area, but also bite test that is oftentimes done with a bite stick or a tooth sleuth can isolate a cusp. And this way, pressure is followed by release, and that allows a little bit of cuspal deflection. And the cuspal deflection is what triggers the A delta nerve fibers in the pulp to trigger fast response pain to the brain, which will let us know that this pulp is vital probably, and there is either a defective restoration that is causing cuspal deflection and fluid movement in the tubules, or that there is a crack in this tooth.
So you get pain on release.
That would be a situation in which there's pain and release, because what ends up happening is the pain upon biting deflects the cusp, okay? And then when you release, the cusp kind of reverts back, and that motion of the cusp creates fluid movement in the dental tubules, which stimulates the A delta nerve fibers, which will then create a sharp pain, which is the characteristic of A delta nerve fibers.
Kind of gives you the histology behind what clinically you're seeing.
That's the whole point. That's why we spend all that time talking about the biological background, because if you understand the biology, I'm a big fan of concepts. If you know the concepts of things, you don't have to follow recipes because you can make sense out of things by just following those concepts. It's akin to, memorizing a formula or understanding mathematics so you can drive it.
I used to memorize a lot of them. I did have my issues. So physics was not necessarily my strong point. But, but I understand.
That's relatable. But the ideal thing would be to kind of be able to understand the biological basis.
No question about it. And it's limiting.
Yeah.
If you don't understand more than and just memorize something.
Absolutely.
If you don't understand the basis of something, it's very hard to extrapolate to what really might be going on, which is the zebra.
Absolutely. Because if there's a slight alteration from your formula, then you'd be basically lost. You can't figure it out. So this is the essence of it, which takes us down to the pulp vitality test, which is ultimately the thing that we're trying to do. This is the culmination of everything we've done here. We've narrowed everything down from outside in all the questions, and now we're down at the vitality tests that tell us about the status of the pulp.
So what are some
Right.
of the things that indicate vitality or lack of?
Or their lack of. Well, actually, from a pathological point of view, vitality of a tooth is defined histologically by its circulation, right? However, all the tests that we have tests the innervation of the tooth, right? So all of our tests are somehow triggering a response from the nerve fibers that are in the pulp. But the real definition of vitality is whether there is circulation in there. Because you could have a lack of, innervation in the tooth and yet have a vital tooth. But unfortunately, we don't have a way to test those, and which what creates some of the false negatives in our vitality tests. Because currently, at this level, at this time of the recording of this video, our technology is limited to only test the innervation of the tooth and not its blood flow, which is the kind of holy grail of understanding if the pulp is vital or not. And we do that through our thermal tests that include the cold and the hot, and then the electric pulp test. These are the three ways in which we stimulate, in terms of the cold and the electric, we stimulate the A delta fibers in the nerve. So that's why you get both of those create that sharp pain, sharp shooting pain. And the heat produces that dull ache, which comes from the C fibers. Okay, so that's one of the difference. There are other tests available that actually do test the circulation in the tooth, such as the laser Doppler flowmetry or some of the partial pressure of oxygen in the pulp through pulp oximetry. But all of those are devices that are very cumbersome. They're still not commercialized at a level that could produce, that could be used chairside on a patient. They take a lot of time, and they're just not practical. So unfortunately, until that happens, we're left to test teeth with using our regular vitality tests. And that is basically the cold test, for example, is the first one. And it's in fact the most reliable test for pulp vitality. Cold test has been shown to be more accurate than electric pulp test, and also more accurate than the heat test. So in terms of reliability, cold test first, EPT next, heat test last. And the cold test is, most people do it using a Q-tip. And I think I probably recommend that we use a Q-tip first using a refrigerant such as endo-ice, for example, as the first step. And people sometimes they use ice sticks. The problem with the ice stick is that it just doesn't get cold enough. The temperature of ice obviously is 0 degrees Celsius. And while that is good for some cases, in some cases where you need to conduct a cold or deeper into the tooth, it may not be cold enough. Mm-hmm. Also, you have the problem of contamination with the ice flowing into the other areas, melting and flowing, and maybe potentially giving you a false negative from an adjacent tooth.
I never liked ice to be
Yeah.
with you. I'll always use the endo-ice.
Endo-ice is really good.
Or refrigerant.
Yeah, refrigerant is ethyl chloride, any of those guys. They're all going to be good. Endo-ice, for example, is very environmentally friendly, and the temperature that it reaches is it's about minus 25 degrees. So it gets pretty cold. Mm-hmm. So it can really penetrate. Of course, the gold standard of cold testing is carbon dioxide because it can get up to minus 50 degrees. And that could really zap into a tooth that you don't get a response from because there's either very large restorations present or there's a lot of calcification. So it can penetrate a lot deeper. But the problem with the carbon dioxide is that it requires a whole capsule and a whole bunch of stuff. And you also run the risk that you could potentially, burn the patient if it just kind of slips and falls and gets on the patient's lip, because it gets to minus 50 degrees and you could get a frostbite if you do that accidentally. So I always like to use the Q-tip on the endo-ice. If the Q-tip doesn't give me a response, the next level up would be to use the endo-ice on a cotton pellet. So you really soak the cotton pellet in endo-ice, you put that on that tooth, they'll get a response. That does get pretty cold. It penetrates pretty deep. If it is vital. And if they don't get a response, then it does tell you a lot of information.
So, Ali, let me ask you a question. Let's say a tooth is vital but not necessarily healthy.
Mm-hmm.
All right. So you put the endo-ice on, you take the endo-ice off, pain goes away.
Yeah.
Versus you put it on and it lingers and stays.
Yeah.
What is it? Give me some perspective of that issue. Is that also related to that patient, or is it more general in terms of there's a specific number of seconds after which there's an issue. You test it on the opposite side, and you find that normal.
Yeah.
How do you relate those?
Yeah, so as usual, you determine first what is your control. So you check the opposite side. You find a normal tooth on the opposite side. That is not. You have to make sure the other one is not pathological, because sometimes that could be a non-vital tooth or something like that. So you check a normal, completely average tooth on the other side, and then from that you draw a conclusion by comparing it to all the teeth on the opposite side.
So it's relative. It's all relative to that patient.
Always relative. And when you do get a response that lingers for longer than 10, 15 seconds and potentially can turn into a throbbing, then that kind of starts to talk about irreversible pulpitis. If it reverts back within 10 seconds to normal, then you're okay. So I usually ask the patient to keep their hand up as almost like a meter to let me know when they feel the pain and then when it goes away. Again, another critical management point at this point is communication. Let them know ahead of time why you're doing this. This is the only way we can test this. I'm sorry, we need to find out, we need to duplicate your symptom. And then proceed to do it as gently as possible. Be ready to remove the cold right away. The goal is to just elicit a response, not to really have him have pain. And, in cases I have found that you have a crown in place, using a cotton pellet instead of the Q-tip, and then placing it on the lingual border of the tooth, right at the CEJ level, where usually oftentimes if there is a porcelain bonded to metal, there is a metal collar. That'll help because you'll get a little bit better transference through the metal collar into the pulp. Also, some patients simply just don't respond to the cold test. Cold test is accurate a high percentage of the time, but in some people, they just do not respond, whether it's something at the level of the fluid movement in the dental tubules or the nature of the A delta fibers. You could test a number of teeth, and you get negative responses in all of them. In that case, some of these tests, vitality tests, may end up being not useful. But it's also in the context of what the patient's chief complaint is. If they're only complaining about heat and not cold, that's when you have to do a heat test. Now, heat tests are something that I usually don't do in the office, but there's a couple of different ways of doing it. You could either use a temporary stopping and heat it up. You could use denture compound, heat it up, place it on the tooth. Make sure you always put a Vaseline on there beforehand so that it doesn't stick to the tooth. And then obviously be ready to have, some kind of a cold if having a problem to kind of, help relieve the symptoms from the heat.
So whenever you're doing a heat test, you always kind of have the cold available to mitigate it.
Yeah, because at certain stages of the disease, when all the A delta fibers are dead and the C fibers are maximum sensitive, if you put cold on the tooth, it actually helps relieve the symptoms.
Right.
Because you get vasoconstriction. But when you put heat, it can send them through the roof. It could be really bad.
Yeah.
It starts and it turns into a throbbing. But another way to test for the heat is to actually isolate each individual tooth and then place a hot liquid, such as water or coffee or something like that. The temperature that is obviously above body temperature, that could potentially trigger these symptoms. Here, it's important to isolate the tooth so that so the stuff doesn't flow everywhere.
Right.
So this is the heat test that you could do. And, finally, if you don't respond to the cold test, you can substitute the electric pulp tester. The electric pulp tester is not something I use routinely in my practice, I'll be honest with you. I just use the cold test for the most part. Mm-hmm. I get the information that I want. If I don't get the information that I want from the cold test, then I may use either the EPT or the heat test. And the EPT, the electrical current in there, it stimulates the A delta fibers, and you get that sharp pain. The reading on the EPT does not correlate at all with the status of the pulp, whether it's reversible or irreversible. All you get from the EPT is an all or non-response. If they get no response at all, there's a fairly good chance that the pulp is dead. Mm-hmm. And if they get a response, however, sometimes you could get a false positive. So the specificity and the of this device is not quite reliable, which is why people don't always use the EPT as a routine. And finally, the inspection of the tooth itself, because remember, we're checking out the pulp and the and the periapical area, but we're also checking the top of the tooth. And to do that, using your Explorer and using high magnification and illumination is really helpful. In that situation, I think the microscope, the surgical operating microscope, has been just a lifesaver for me as an endodontist clinically, because I can see a lot of problems that are present even before we start. I may see a crack that runs across the tooth, a mesiodistal crack that is fairly deep. So I will have an information about that in advance. I can check the marginal integrity of some of these restorations that are present that could be leaking and could be causing reversible pulpitis. So that is really helpful, and having illumination and magnification together goes a long way in trying to consolidate the plan. So at this point, we've had the intraoral examination and the extraoral examination, and now we're ready to go ahead and take a look at the radiograph, even for the first time, if we really want to be religious about it, because most of the time the X-ray's already been taken. But frankly, it's always best to look at the X-ray at this stage of the game, so you're not even biased by looking at the X-ray in advance. Mm-hmm. So this is it. Let's come back for the next lesson and just do a little bit of a radiographic examination, which we're going to come back in the next lesson.